Hey, how's it going? We're gonna be chatting in a couple minutes from now, but I want to make a quick demo displaying an idea I had for Palantir. I know you guys in hospitals try to make data-driven decisions everywhere, especially on the administrative side of things, to help save the hospital some money and save the patients some of their time and potentially improve their health. But this initiative I'm running for a little while, Radiel Health, I want to answer a question of what if we can go even deeper to the actual, like almost molecular level and try to save the hospital patients some time and money from that. So I want to give some medical background first. Kidneys. What are kidneys? You know what they are. They help filter waste and excess fluid from blood into urine. And they fail relatively often when if you have diabetes and high blood pressure. Two big things in the West. And it impacts a lot of people. Hundreds of thousands of Americans and Canadians have kidney failure. At the very last stage of kidney disease, you need kidney dialysis. So what is dialysis? Dialysis is this like pretty much this procedure where you filter your blood through this external machine. But to get that blood filter, you need a bridge, this AV fistula between an artery and a vein. And this has a relatively high rate of failure. In 5 years, we have a survival rate of around 40%, depending on patient age and general health, and that could be improved. But why does it fail? So, for a fistula to work, it needs to undergo maturation. Maturation involves vein enlarging, wall thickening, and ease of accessibility. And there's two main reasons why fistulas fail. One is stenosis, the narrowing of the blood vessel, and the other is thrombosis, a blood clot blockage. So, top medical institutions use CFD, or computational fluid dynamics, to predict key parameters such as wall shear stress. Wall shear stress is the pressure of how the blood hits the wall at certain points along the vascular structure. So, regularly, around 20 to 60% of fistulas fail to mature after a year, but after the addition of the CFD metrics, this failure rate dropped to 10-20% reliably. But what is CFD? Well, CFD, computational fluid dynamics, is just this like a bunch of simulations that simulate how fluids, in this case blood, flow through devices and vessels. Here, the device or vessel is our arteries. However, these were done in world-class institutions, and it's not accessible for most hospitals around the world. And there's three main issues with CFD. One, it costs too much. Two, it takes too much time to actually run. And three, you need extra physicists to set the results. So, what's our proposal? At Radio Health, we want to answer this question. Can a machine learning surrogate train on high fidelity CFD outputs from patient CT scans or ultrasounds, predict key flow parameters like pressure, velocity, shear stress in seconds, with actually comparable to traditional CFD simulations? So our flow pipeline that I envision is this kind of four-stage thing. So here, the clinician starts off with a series of patient ultrasounds or CT scans, stuff that's already very accessible and that they already do in the clinic. Then our platform turns those images to a 3D mesh. Our model is run, and the prediction of hemodynamic values are the new mesh is outputted. And finally, those values are then used by clinicians to better inform their decisions. So we're not doing this without our awesome mentors. Dr. Sean Peterson he's a professor at U Waterloo, and he's kind of mentoring us to make sure our models are very physically accurate. And Dr. Aaron Fenster, he's a medical physicist from the University of Western Ontario. He's actually one of the inventors of 3D ultrasound, and he has this technology that can turn an ultrasound to a 3D mesh, the very first part of our pipeline. But how about parts 2, 3, and 4 of the pipeline? Let me just demo that. I made a quick demo last night. The model that like backs all this was made over the course of a couple of months, and I'll show you how we train it. But first, I want to take you to this side of the screen. We have a bunch of bifurcation angles and mesh resolution, and like the size of the child. And what I mean by that is that first we train our model on this lid-driven cavity. It's the simplest problem in physics, and we just wanted to ensure our model was very physically accurate. And if you run this lid-driven cavity, which is just fluid flowing through this box and swirling around, and you run this lid-driven cavity through a model, you will get 99% the same results, which is very, very accurate. And it's awesome. So from that, we move on to a much harder problem of bifurcation. These are idealized, and we have a bunch of different meshes that differentiate and the angle between the bifurcation, or where the two child vessels are, and the size of the child vessels. And the reason why we did that is because our main hypothesis is because all our bodies are very different. So this our vascular structures inside of us, even though they're pretty much the same, the slight variations kind of impact how the blood can travel through us, which could mean slight differences in how the clinician or the surgeon needs to operate on us. And why do we do a bifurcation? Well, if you notice, an AV fistula is very similar to a bifurcation. It's a very common structure found in our body. So you want to inference on that. So um, I'm going to choose a random bifurcation angle, let's say 30, max position of 50, 500, which is like the size of the child, and a Reynolds number of 500. Reynolds number is like a knob for the smoothness of the flow. So it's a relatively smooth flow. And let's run the prediction. So while we're running our prediction, I want to talk about how the model actually works. So we have a dual encoder system. One, on the top, we see we can encode the actual flow of the whole thing. So we can encode stuff like Reynolds number, how the inlet works, the turbulence, the outlet type, it's laminar, fluent, turbulent, all that stuff. And on the bottom, we actually build a graph that represents the whole geometry of the whole mesh. And in doing so, at the end, we get this concatenation of both these things, and we can predict stuff like wall shear stress, velocity, and pressure, which could be used to later inform decisions for the clinician on where to like do an incision, for instance. Yeah, so it's done. And if you see here, we have our predictions. We have our legend here of wall shear stress from 2 to the power of 10 to the negative 4 to the power of 10 to the negative 5. You can see there's color coded. And let's say you're a clinician and you want like a certain point. You want to see how the blood flows at this corner right here. What you can do, you can go over here. You can inference on that one point, and we'll get our inference in just a second. And we see here we have our Walsh summary. So yeah, if you see here now, we've inferenced on the whole mesh and a very specific point on the mesh. So it depends on what the clinician actually needs the data for, but it's essentially another tool in their toolbox to make better data-driven decisions. And they can kind of see in the future of how blood will flow in this person's body and make decisions based off that. And one thing I wanted to tinker around with was that can we use LLMs here too? So let's add our selected point to the chat. I'm using Claude here. And like, I don't know, I think it'd be really cool if clinicians can kind of like talk to their patient's vascular structures and see how the blood flows through it, and they can make potentially more data-driven decisions from that. Um, but yeah, it's thinking a little bit, but that's kind of the main idea of the whole platform. To summarize, my main goal here was to create something that connects to the things that they already do. So if a clinician already does an ultrasound, then okay, cool. We can take the ultrasound, turn it to a 3D mesh, and then from that 3D mesh, we can predict the flow, the blood flow through it. Then we can like inference on certain parts, certain points that the clinician finds interesting or they might need. And at the end of it, they can kind of like talk to the mesh, see what it actually means for them. If there's a possibility of stenosis or thrombosis, depending on if they actually do a certain incision in certain places or not. So that's the main idea of radio health, and it's something that I think would be really cool to work on at Palantir because you guys have the resources, the technology, and I think it'll be really cool if there was more initiatives at Palantir that don't just go at the administrative level, but also the body level. Because there's so much data in the body that we can unlock, and we can save a lot of lives, save a lot of money for the hospital and the patient, and just have fun building it. So yeah, thank you. That's kind of my demo.